to the dais. We want to make this session a bit different because my presentation is, I want to give some highlights of the radiotherapy facilities of our country. And after that, it will not a panel discussion, it will be a discussion. We will be discussing how to make a way out of it. May I request my panel members, Dr. Tamaki, Dr. Stephen, Dr. Alia, Dr. Asma, Dr. Mustafa Aziz, Dr. Syed Akram Hussain, and Dr. Tawfiq Hassan Firoz, all to come to the dais. And Dr. Masud Rana. So, dear audience, we are going to have this session for an hour. I will try to give a snapshot of the radiotherapy facilities in our country, and at the end, I will try to make how we can make a way out from there. And with the discussion, my esteemed panel will be guiding us for a way out from this. So I am Dr. AFM Kamal. I am the Scientific Secretary of Oncology Club. Professionally, I am a clinical oncologist. I want to acknowledge that the works that was done, we have done some homework, paperworks. I want to acknowledge Dr. Al Mamoon, Dr. Tawheed, and Dr. Arif, who did all the job, and I am only presenting the data. We have not forgotten COVID-19. It was a havoc. We were scared, world was shut down. Things were not moving, and everybody gave huge attention. Whole world resource was mobilized to get out of COVID-19. Why? Because it was a pandemic. It affected the whole world. It caused many deaths. It caused many financial impact. People say cancer is a pandemic by number, not by definition of epidemiologist. But the more problem is COVID comes, COVID goes. Cancer pandemic will never go. It will persist. In an epidemiological strategy, we can say that cancer is an epidemic of chronic disease. Why we are claiming cancer as an pandemic disease by number? If you look at this, that in 2020, there was 19 million cancer in the whole world and 10 million cancer deaths. And there was a projection from 2022 to 2050. It was projected that the worldwide 20 million will be the number in 2020, and it will rise to 36.3 million in 2050. But the dangerous part is the growth will be 142% in the low income country, and medium income country it will be 100%, but high income country it is something around 50%. So we need to think about this, the projection. We are in a land where there is a projection of 140% growth. We had the opportunity to publish a Lancet series paper where we tried to gather some data of SAARC countries, including Bangladesh, because countries like Bangladesh always struggle for data. And there we have shown that in the SAARC country, the rise of cancer incidence is around 62%. And when the mortality is predicted, the rise is 67%. But the problem is here in Bangladesh. If I look at the mortality to incidence ratio in Bangladesh is 70% when it is USA is only 25%. Professor Saiful make a gross calculation of disability adjusted life year, and he have shown that with this there is a projected economic impact of $14.2 billion in Bangladesh for cancer. But there is a paradox in cancer treatment scenario. In Lancet, they have published that more than 50% of the population reside in low-income and middle-income countries. But in the low-income countries, more than 9 of the 10 patients with cancer do not have access to radiotherapy. So there is again a small snapshot telling that what a disparity exists in the whole world. This I have taken from direct database is from IAEA, where it is shown that there are 8,800 radiotherapy centers having 16,280 machines, EBRT machines. But the next column, if you look, in high-income country, one machine is allocated for 130,000 people. But in low-income country, it is one machine is against 15.6 million population. I want to draw your attention to the additional column that even the low number, these are not evenly distributed. Most of the country is having a centrally distributed machines. And they also struggle for poor service contract, maintenance contract, which cause struggle to have uninterrupted service. And the running cost, sometimes for a small running cost, they cannot run the machine. And there is also staff scarcity. WHO have taken a decision by 2025. They want to cut down 25% of the mortality of non-communicable disease, where cancer is also a part of that. To achieve that target, there is at least 1.5 million deaths from cancer will need to be prevented each year to achieve this target. But the initiative till now is not that great. LMIC have only 5% of the resources, but 80% of the global cancer burden. So this is Bangladesh, a small country, big population and huge burden. If you look at the comparison of Bangladesh and the remaining world, you see the blue bar is longer in remaining part of the world. That means in Bangladesh, blue and red is very nearer. Incidence and mortality is quite kissing each other. But the remaining part, the incidence is much longer graph than the mortality. I was trying to look into the data of direct database of IAEA, where it shows that Bangladesh have Bangladesh have 37 radiotherapy machines. We need to understand this is a database created by volunteers like us who update it. And another problem is, here they put at the number of the machines, they don't mention whether it is functioning or not. So I wanted to make a quick survey in our country using IAEA form. The very highlight is that I found that the number of functioning machine in our country is 29, where 23 is LINAC and 6 is Cobalt, and majority of the LINAC is in private center. Yes. I wanted to look at the waiting time. And you can see that the government, the waiting time range from 6 months to 2 months, average 3.83 months. And in private also, there are private centers where there is 4 months delay. And in an average, there is near about 1 month's delay waiting time in private centers. In capability, in government centers, 4 centers are having 3D CRT, and all private centers are now having 3D CRT capacity. But in IMRT, the government in 3 centers is having capacity, but the private majority 12 is having the same facilities. SRS is not that great, but many of the centers is having the capability, though not practicing much. So based on this information, we tried to create a picture that what would be the cancer burden in Bangladesh. We took the use the guideline of IAEA that one so from population, how to find out the need of the radiation machine, and also we took the Globocan data to figure out the number of patients. We used the data of 2022 census and we projected the new cases of 2025 based on Globocan 2022 with a 10% increase. And we used that 50% of the patient will be requiring radiotherapy. And with this capacity, we have seen the Bangladesh needs around 209 machines. Based on 450 patients will need one EBRT machine, which is also an IEA recommendation. So my friend Mamoon made this very busy slide, which we struggle to understand. So we want to make it more simple. So look at Dhaka city and Dhaka division is separated, and then I have divided all the divisions, and you can see the distribution of the patient is this. There's 180,000 patients in whole Bangladesh, and the division wise, this is the distribution. Dhaka, Chittagong and Sylhet is fairly near to each other. So that I want to look at the top 5 diseases. What about the breast cancer? You look at again, the breast cancer is like this, but this is not the total number, it is half of the number because we are looking at the number who will need radiotherapy. So the number here for breast cancer is 7,148 is actually half of the projected number of breast cancer in Bangladesh. So we can assume that something around 14,500 with the breast cancer patient, and the Dhaka division is leading with the number. It is not who are treated, it is where from the population should represent. Now Dhaka is treating much more patients. Similarly with cervical cancer, the patient requiring radiotherapy treatment is like this, around 5,300. For lung cancer, division-wise, this is the distribution. And the total number is around 14,000, where 7,000 will be needing radiotherapy, we assumed. Esophagus cancer, we have gone through the Globocan data, so esophagus is one of the top 5. Even many debate is on this. And 27,000 esophagus cancer is projected and 13,000 will need the radiotherapy treatment. And lip oral cavity again, it is a high number, and it is 8,800, and there is 16,000 is the total number. So and others is a big number because it is out of now common 5 is 49,674. So if we look at the total number requiring radiotherapy in all division is 92,000 patients, they will need radiotherapy. So this is the continuous slide, number, figures, where the division, but let's look, what is the reality of the machines? If you look at how much we need and how much we have, in Dhaka, we need 14 machines, Dhaka city, we have 21 machines. In Dhaka division, we need 42 machines, we have 0 machine. We need 41 machines in Chittagong division, we have only 3 machines. In Sylhet division, we need 26 machines, we have only 1 machine. In Rajshahi division, we need 22 machines, we have 4 machines. In Khulna, we need 21 machines, there is no machine. In Borishal, need is 12, availability is 0. In Rangpur, again, similar picture, 16 requirements and there is no machine. In Mymensingh, we need 15 and there is no machine. No machine means no functioning machine, clinically functioning machine. So there is a need of 209 machines, and at this moment, clinically functioning machine number is 29. So there is a deficit of 180 machines. So globally, there is no 100% penetration of radiotherapy. People are happy if they have 50% of the requirements. So let's assume what is the picture if it is 50%. Still, there is a huge gap and the difference is 75 machines. You will be happy to know that 8 divisional cancer center is coming up and we are expecting 16 more LINAC will be added once this center will be functioning. So I wanted to see what will happen after this 16 machine is added with on our map. Yes, situation will improve, but still there will be a gap of 60 around machines. So that is our manpower, machines. What about manpower? Again, Lancet Oncology is publishing that recent analyses have shown in LMIC only 5% of the optimum number of radiation oncologists recommended for their population exist. So the picture is also very scary for manpower. So again, we took the help of IAEA guideline of one radiation oncologist requirement for 250 patients. And we identified that in Bangladesh, this is the division-wise distribution, and there is a need of 368 radiation oncologists. We took the guideline of one physicist for 400 patients policy of IAEA, and we identified that there is a need of 230 medical physicists in our country. And we took the guideline of 125 patients require one radiotherapy technologist, and we found that there is a need of 737 radiation technologists in our country. So if we look at the published data in the SAG paper series, it is reported that there are 250 radiation oncologists, 22 medical oncologists, 47 physicists, and 47 pediatric oncologists, 70 medical physicists, and 115 radiotherapy technologists. So I took that extrapolated data and compared with our requirements and found that there is a shortage of 118 radiation oncologists, 160 medical physicists, and 662 radiation technologists at this moment. So somebody may ask that why we are talking so much about radiotherapy. If we consider cervical cancer as an example, it has been shown that 70% of the cervical cancer patient will be benefited from radiotherapy treatment. And it is estimated to improve 5 years overall survival by 17% above the contribution of surgery and chemotherapy. And if we can close the radiotherapy gap, next 20 years will save almost 10 million life years in low-income and middle-income countries for cervical cancer. So, like this, almost everywhere there is a big impact of radiotherapy in cancer care. So radiotherapy is something which is required in around 60% of the patient, both in curative and palliative, but it is also the cheapest treatment modality. This is a myth. Because the machine is expensive, people think radiotherapy is a very expensive treatment. Again, it was an IAEA publication they have shown in 2017 that cobalt machine per exposure cost is $4.87. And if we consider 30 fraction, it will cost only $146. LINAC 30 fraction cost is $330. At that time, they considered the chemotherapy cost per treatment is $600 per treatment, the whole cost. But in the era of immunotherapy and targeted therapy, I'm sure this 600 became 6,000 or more. So is it worthy to invest in radiotherapy? In the Lancet Commission, they have shown that comprehensive combined scale-up of imaging treatment, primary medicine, radiotherapy, and surgery, and care quality would prevent 9.6 million deaths worldwide between 2020 to 2030. An assessment of global lifetime productivity gain also established that scale-up of access to imaging would provide a return of investment of $179 against $1 investment. But when we look at the budget allocation for cancer in a review, it was seen that a small percentage of the cancer care is radiotherapy cost. It is only around 7 to 8%. Radiotherapy is often perceived as an expensive treatment. In Europe, it has shown that radiotherapy costs 7.8% of the cancer care budget and less than 0.5% of the whole healthcare budget. In 2035, there would be a projected economic benefit of $365.4 billion and human capital return of $104 billion if radiotherapy service were scaled up in LMIC. So it is a where not to invest rather than radiotherapy. So what about Bangladesh? Unfortunately, in the SAARC countries, after Afghanistan, Bangladesh invests the minimum of GDP in its health sector. So as a result, the out of the pocket is one of the highest, around 73% in Bangladesh population. This is the publication I found this year, last month they have published, and they have showed in Bangladesh out of the pocket cost of cancer care is $6,540, which is 2 times average annual household income. About 90% of the household face distress financing due to cancer. So what are the challenges in our country? I think the challenges infrastructure is equipment shortage, maintenance, and disproportionate distribution. And financial barrier is initial high cost investment out of the pocket cost. And in manpower, we have inadequate manpower, and whoever we have, they are not adequately trained. So what are the recommendations? My recommendation is we need to popularize radiotherapy treatment with its justification. We need to talk. We need to discuss with policymakers, with colleagues, with opinion leaders that we need radiotherapy, which is not an expensive treatment, it is a cheap treatment but effective treatment. We need to expand the radiotherapy facilities, but it should be need-based. We should not gather all the machines in Dhaka, keeping Khulna and Borishal having no machines. And we should be judicious that all high-end machine may not be required at every part of the city or country. We need to increase our manpower. We need to make a long-term plan. And we need to take a plan how to train our radiation oncologists, medical physicists, and radiation technologists. And in this training program, we should more focus on local training than sending them overseas, which is a fancy thing, I believe. And we can have remote training. We can collaborate with our colleagues, friends, and agencies like IAEA. We need to ensure uninterrupted service. Government goes for warranty, but never go for maintenance contract. So after warranty, machine struggles. So we need to ensure the maintenance contract is done for the 10 years so that there is uninterrupted service. And finance is very important, and adequate finance should be there, because investing 50 crore only for 10 lakhs, the machine is struggling. This we need to talk. And definitely we need to do some research which will show us light and path for the future. So with our existing facilities, I think we can grab hypofractionated protocol. It will save time, save money, and allow us to treat more. Globally, it has shown that the hypofractionated breast and prostate cost 2.2 million more additional patient treatment opportunity, where 1.8 was for breast and 1.4 was for breast and 0.8 was for prostate. In centers where there is a short duration, we can extend the duration of treatment time so that we can accommodate more with the same machine. We can start incorporating SBRT. It sounds fancy, but it's an interesting thing. In Mongolia, IAEA has done a study, and they have shown the result and cost of SBRT is cheaper than conventional radiotherapy, and outcome is better. If we can do SBRT, we can do SBRT to the oligometastasis, which will reduce the requirements of systemic treatment, which is toxic, both physically and financially. We should start thinking of incorporating AI, which will reduce our work burden. And we should look for newer technique to adapt. Thank you. Thank you very much.